Yeah. Are you able to hear clearly?
Yes, sir.
Okay. So how will you divide the larynx? What are the parts of the larynx? Chanakya.
Yes, sir.
Yeah, laryngeal parts. Grossly will divide the larynx into how many parts?
Epiglottis,
Yeah.
vocal cords,
Mm.
sir. Supraglottis,
Yeah.
glottis, and infraglottis, sir.
Okay. So these are the three subsides. Supraglottis, glottis, and the subglottis. In supraglottis, we'll see the epiglottis or epiglottic folds and the arytenoids. Okay, in glottis, true vocal cords. In subglottis, just below the vocal cords to the lower border of the cricoid cartilage, that is the subglottis. So these benign lesions can occur anywhere in the larynx, any part of these three parts of the larynx, either supraglottis or glottis or subglottis. So the important thing is in benign lesions of the larynx are rare compared to the malignancy. So almost 80 to 85% of the lesions of the larynx are the malignant lesions. So remaining 15% only will see these benign lesions. So that means very rare these benign lesions compared to the malignancy. So they are again broadly classified into non-neoplastic and neoplastic. Okay, neoplastic are true benign lesions and non-neoplastic lesions. Again, in non-neoplastic, it is solid and cystic lesions. So anatomy, you all know about the anatomy of the larynx. So it extends from the C3 to C6 cervical vertebra. So these are the three parts. Vocal cords will extend from the middle of the thyroid cartilage to the vocal process of the arytenoids posteriorly. Anteriorly, middle part of the thyroid cartilage to the arytenoid vocal process of the arytenoid posteriorly. So anterior 2/3 or 3/5 is the membranous part and posterior 1/3 is the cartilaginous part of the vocal cords. Coming to the histology of the vocal cord. So this is having the four layers. The superficial layer is the epithelial layer, which is formed by the respiratory epithelium and also non-keratinized stratified squamous epithelium. So just below the epithelium, there is a lamina propria. So in this again, superficial, intermediate, and the deep part. The superficial part of the lamina propria, we call it as Rinke space. Okay, just below the epithelium, there is a space that is the Rinke space that comes under the superficial part of the lamina propria. And within the after that, there is a muscle that is the thyroarytenoid muscle or vocalis muscle. Vocalis muscle is nothing but internal part of the thyroarytenoid muscle. So epithelium, Rinke space, intermediate and deep lamina propria, and then muscle. That is the vocalis muscle. That is the internal part of the thyroarytenoid muscle. So how will you examine the larynx to know the exact pathology of the larynx? Usually in OPD in our department, usually we'll do the video laryngoscopy, that is the rigid video laryngoscopy. So there is one more instrument, that is the stroboscope, so that you can see the minute details of the vocal cords, that is the video stroboscope. So this gives a slow motion perception of the mucosal waves of the true vocal cords. So you can have the clear pathology, any problem in the vocal cords also without seeing the gross appearance of the lesion. You can see the physiology or movement of the vocal cords by using this video stroboscope. So to detect the early lesions of the vocal cords, we need to use this video stroboscope. So this is the classification for the benign tumors of the larynx. This is broadly divided into, I already told, non-neoplastic and neoplastic. Again, in non-neoplastic, it is solid and the cystic lesions. In solid lesions, vocal nodules, vocal polyp. So this classification is important, and also all these vocal nodules, vocal polyp, Reinke's edema. These are the important 4 marks question for you in the exam, in the final examination. So all of you listen carefully. This is a important chapter in final examination. Definitely you'll get the 4 marks or 2 marks or essay question. So in this, vocal nodules, vocal polyp, and Reinke's edema are the important. And in cystic lesions, ductal cyst, saccular cyst, and the laryngocele. In neoplastic lesions, papilloma. Papillomas are the most common benign neoplastic lesions. Chondroma, hemangioma, granular cell tumor, and the glandular cell tumor. And the other rare true benign lesions are the neurilemma, rhabdomyoma, lipoma, and the fibroma. So coming to the non-neoplastic solid lesions. So number 1 is the vocal nodules. So these usually will see at the junction of the anterior 1/3 and the posterior 2/3 of the vocal cord. So here if you observe, this is the vocal nodule. So this is the anterior part and this is the posterior part of the glottis. So till here there is a membranous cord, here that is a cartilaginous cord. This is attached to the vocal process of the arytenoid cartilage. So at the junction of the anterior 1/3 and posterior 2/3 of the vocal cords, you will see these vocal nodules commonly. And why you will see the commonly here, the reason is here there is a maximum vibration of the vocal cords during the phonation. So during the adductor movement, you will get the phonation or speech. So in that, this is the maximum vibratory area of the true vocal cords. So there is a more mechanical trauma to the free borders of the vocal cords compared to the rest of the vocal cord. So that's why you'll see these vocal nodules. This is the commonest side, or mostly you will see the here only vocal nodules, anterior 1/3 to the posterior 1/3. So this usually you'll see in the free medial part, slightly below the free edge of the vocal folds or vocal cords. So it forms the pinkish fusiform swelling. Sometimes it can be discrete, rounded, and whitish in singers. So the main etiology for this vocal nodule formation is the voice abuse or misuse. Voice abuse or misuse of the voice, that is the reason to develop these vocal nodules. So there is a progressive hyalinization with overlying hyperplastic squamous cell epithelium. And there is a basement membrane thickening and slight parakeratosis if you see the histopathology of these vocal nodules. So coming to the symptoms of the vocal nodules, in early lesions, you will see there is a delayed phonatory onset during the singing or using the high notes. In late, symptom is the increased breathiness, roughness, or hoarseness of the voice. So in late stages, there is increase in size of the nodules, so that you will get this breathy voice and hoarse voice or rough voice. In early stages, you will get the delayed phonatory onset. So diagnosis, if you want to diagnose early or if you want to see the early lesions, you have to use the video stroboscope, or in late stages, you can use the video laryngoscope. Management, voice therapy, surgery, and the post-operative voice rehabilitation. So if the lesions are very small, you can educate the patients about the voice therapy or proper use of the voice without any surgical treatment. If the nodule size is increased, it is causing the phonatory gap. So these two nodules meet in the midline. There is a phonatory gap. While phonation, there is a phonatory gap, that is called the hourglass shaped glottic chink. So if the lesion is bigger in size causing the voice problems, then you need to go for the surgical treatment, that is by using the microlaryngeal surgery. So you can use the cold instrument like this in this picture, or you can go for the directly laser surgery, that is the CO2 laser. So in cold instruments, we need to hold this nodule with the grasping forceps, then cut the base of these nodules in the free border of the vocal cords without damaging the underlying lamina propria or vocal ligament or thyroarytenoid muscle. So without damaging, so we need to precisely excise these nodules. So if you damage this underlying structure, again the patient will get the rough voice or hoarseness of the voice. So doing the surgery is important. During this surgery, we need to take the utmost precaution to prevent the damage to the underlying structure. So because we are doing the surgery for voice problem, again if you create the voice problem after doing the surgery, it is a crime. So second, this benign lesion of the vocal cord is solid lesion is the vocal polyp. So here also the pathophysiology is same. So voice abuse or voice misuse is the usually etiology for this vocal polyp formation. So here there is intermittent severe voice abuse. So then we will see the edematous polyp. So this polyp is constituted by the plasma, and in case of the hemorrhagic polyp like this, in severe intermittent voice abuse, there is a rupture of the microcapillaries in the submucosa and there is accumulation of the blood in the submucosal layer. Then you will see the hemorrhagic polyps. These polyps may be sessile or pedunculated. These are the sessile. So there is no peduncle. These are the sessile. So we are seeing the upper free surface of the true vocal cords. Symptoms same like vocal nodules. There is a rough voice or hoarse voice, usually hoarse and husky voice. So almost normal if in case of the pedunculated vocal polyp. This is important. So if the pedunculated vocal polyp is there, during the phonation and respiration, that pedunculated polyp will move above and below. So into the supraglottis or into the subglottis. So the free borders will attach in the midline. So there is no much voice change in the case of the pedunculated polyps. So if the sessile polyp on the free border, then you will see the major voice change. Depending upon the size of the polyp, if the polyp size is larger, then patient may develop this respiratory obstruction also because of the mass effect. This mass will obstruct the glottic region. So diagnosis again by stroboscopy or video laryngoscopy. Management is surgical treatment. So that is by the microlaryngeal surgery by using the suspension microlaryngoscope. Same like vocal nodules. So the main difference between the vocal nodules and polyp is vocal nodule is the bilateral. Usually you'll see the both the vocal cords will involve in the vocal nodules. In vocal polyp is a unilateral disease. The site of origin is same at the junction of the anterior 1/3 to the posterior 2/3. So we need to inject to delineate the lateral border of the polyp, we need to inject the saline with adrenaline. So this adding the adrenaline to this polyp region infiltration will reduce the hemorrhage during the surgical treatment. So we can grasp the polyp with the cup forceps, then we can dissect the lateral border of the polyp. So third benign lesion, that is the solid lesion, is the Reinke's edema. So this is nothing but there is accumulation of the gelatinous fluid material in the Reinke space, that is the uppermost layer of the lamina propria, that is just below the epithelial layer of the true vocal cords. So it is a typical inflammatory and edematous lesion. On macroscopic examination, you can see here there is a lot of edematous vocal cord on the one side. So here also you can see bilateral vocal cords are edematous, filled with like a fluid-filled vocal cords. So there is yellowish mixoid infiltrate of the vocal folds on the submucosal space associated with the dilated capillaries on the superficial layer of this vocal cords. So this On histology epithelium, you can see there is a irregular thickness with some acanthosis and parakeratosis, submucosal edema with slightly lymphocytic and histiocytic infiltration with dilated capillaries in the submucosa. So symptoms, all the symptoms will depend upon the site of the lesion in the larynx. So usually if any lesion which affects the or which involve the true vocal cords, the main symptom is hoarseness of voice. So there is an increased harshness of voice during daytime and with low voice pitch. And if it is the larger edematous lesions on both the sides, it will cause the dyspnea also. So there is a grading for this Rinke's edema. So grade 1 is marginal edge edema. You can see in this picture only marginal edema. Grade 2 is obvious sessile swelling. This is the grade 2. Here grade 3 is large bag-like swelling and grade 4 is partially obstructing the lesion in the medial borders of the vocal cords. So diagnosis by the directly you can see the this edematous vocal cords and the video laryngoscopy. So the most common etiology for this Rinke's edema is voice abuse, misuse, and also smoking. So if the patient is smoker, we can advise the patient cessation of the smoking, short-term pre-operative speech therapy. So surgery is the definitive treatment if it is well established Rinke's edema, and post-operative speech rehabilitation of the patient. So surgical treatment by using again under magnification by using the microscope, we need to expose the vocal cords, the suspension, laryngoscope. Then we need to give the incision in the superficial layer of the epithelium in the towards the lateral border of the vocal cords. Then we need to suck the gelatinous fluid from the Rinke's space by using the suction apparatus. Then we need to replace this epithelium into the again, so that patient doesn't have any voice changes post-operatively. Then we can apply this tissue glue in the incision site so that it will attach properly without any post-operative voice problems. So fourth one is the contact granuloma. Most commonly it is seen in the men. So the etiology for this contact granuloma is chronic coughing. So those who are suffering with the allergic cough or chronic cough, dry irritating cough, there is a mechanical trauma in this vocal process region, vocal process of the arytenoid region, and also we'll see in the GERD, that is gastroesophageal reflux disease. So that is the etiology for contact granuloma. There is ulceration of the mucosa followed by the granuloma formation in the vocal process of the arytenoid region. So there is a forceful slamming together of the arytenoids, trauma to the thin mucosa and pericardium overlying the cartilaginous glottis, that is the posterior one-third of the glottis, at the region of the vocal process of the arytenoids, leading to the ulcer formation. Ulcer healed as a heaped up granuloma. So symptoms are the usually throat discomfort, pharyngeal paresthesia, ipsilateral reflux, otolgia, and slight husky voice. Those are the symptoms. So diagnosis by the video laryngoscopy, slight whitish bilobed polypoid lesion over the medial aspect of the vocal process of the arytenoid. So treatment is anti-reflux therapy, that is the PPIs 40 to 80 mg per day, specific breathing exercise, and maturation and resolution with the spontaneous expulsion of the polyp may occur within 3 to 6 months with the medical treatment. If not occur, then we should go for the surgical treatment. Simple endoscopic resection is not advisable. So because there is a high chance of recurrence, so endoscopic surgery by using the suspension microlaryngoscopy should be investigated. Granuloma or polyp is removed with the ultra pulse carbon dioxide laser set at the rate of 150 millijoules per centimeter square. So better to use the CO2 laser rather than the cold instruments. It will prevent the recurrence of this contact granuloma. Fifth one is the intubation granuloma. This is different. So there GERD or repeated cough is the etiology. Here intubation granuloma after endotracheal intubation. So improper intubation, that means if you keep the tube for the longer duration or if you use the improperly larger size of the endotracheal tube, there is a damage to the vocal process of the arytenoid, then you will get these kind of intubation granuloma. So in the name itself, it is due to the intubation, endotracheal intubation. So it is a bilateral and associated with the ischemic erosions and ulcers of the glottis and the subglottic region. Most common site is the medial aspect of the arytenoids. Other causes are the endolaryngeal trauma during the rigid bronchoscopy and also direct laryngeal manipulation. So intubation granuloma pathophysiology is pressure necrosis due to indwelling endotracheal tube causes the ulcerated lesion over the mucosa of the true vocal cords in the posterior part. So medications for this is antibiotics, proton pump inhibitors, corticosteroids. Then endoscopic removal by using the suspension microlaryngoscopy. So if there is a significant airway compromise, then you should go for this surgical treatment. So other lesion is leukoplakia or the keratosis. So it is mainly it is a precancerous condition. If you leave this keratotic lesion, there is a chance it converts into the carcinoma in situ or malignancy of the vocal cord. The common site for this keratosis is the true vocal cord. Like this, there is a epithelial hyperplasia involving the upper surface of the vocal cord, either one side or both the sides. Here you can see only on one side. So there is a white plaque or the warty growth over the vocal cords. So because it affects the true vocal cords, usually the symptom is the hoarseness of voice. So treatment is we need to stripping of the vocal cord and we need to subject the tissue for the histopathological examination. So if it is only hyperplasia of the epithelium, that is the leukoplakia, so there is no need of any further treatment. If there is any carcinoma in situ or malignancy, then we need to give the again radiotherapy, post-operative radiotherapy. So the other rare tumor is the amyloid tumor. Usually you'll see in the old age males around 50 to 70 years. So there is a deposition of the amyloid material in the vocal cord region, ventricular gland, that is the false vocal cords are in the subglottic area. So on endoscopic examination, there is a submucosal mass. Symptom is hoarseness of voice or difficulty in breathing. Diagnosis is biopsy and special staining of this mass by using the Congo red. Treatment is surgical removal. So then coming to the cystic lesions, ductal cyst or mucus retention cyst. So there is a obstruction to this mucus and serous secreting glands. So there is a formation of the fusiform yellowish swelling over the vocal cords. The common site is the vocal cord. Here you can see this cystic lesion. Symptom is rough voice or harsh voice. Sensation of the increased effort for the singing or speaking. So diagnosis by video laryngoscopy or stroboscopy. Chanakya
Yes, sir.
Yeah. Are you following the class?
Yes, sir.
Okay. So these cystic lesions, ductal cyst or mucous retention cyst, if there is obstruction in this cicatricial obstruction in the this secreting gland ducts. So we can diagnose by the stroboscopy or video laryngoscopy. So usually the symptoms are the rough voice and the harsh voice and sensation of the increased effort on speech. So preoperative speech therapy, surgery and post-operative rehabilitation is the treatment options. So superior chorda to be close to the lateral border of the cyst. Cyst is dissected by the blunt micro dissector. So we need to, cyst wall is very thin, so that we need to precisely excise the intact cyst without rupturing the cystic wall. If you rupture the cyst during the removal, it is very difficult to remove the entire cyst. So after removal of the cyst, mucosa will fall back onto the vocal ligament, and again we can apply the tissue glue. Second type of the cystic lesion is the saccular cyst. So it is seen in the laryngeal ventricle, that is nothing but space between the false and the true vocal cords. So this is the true vocal cord, this is the false vocal cord. So obstruction to the orifice of the saccule causes the retention of the secretions and distension of the saccule. So anterior saccular cyst will obscure the part of the vocal cords. Lateral cyst will extend into the false vocal cords, aryepiglottic holes. Even they may appear by piercing the thyroid membrane in the neck. So treatment for this saccular cyst is marsupialization or endoscopic excision. Third one is the laryngoscele. This is important. So it is an air-filled cystic swelling due to dilatation of the saccule. So this is depending upon the size of the lesion and position or of the lesion. These are divided into internal, external, and the combined. If the laryngoscele is only present in the within the larynx, that is the internal laryngoscele. If it pierces the thyroid membrane, that is the hyoid bone, thyroid cartilage, thyroid membrane, by piercing the thyroid membrane, it appears in the neck as a external cystic swelling. That is the external laryngoscele. Sometimes you'll see both internal and external, that is the combined. So it is arises from the raised transglottic pressure as seen in the trumpet players and the glass blowers. So if there is any rise in the transglottic pressure, then you will see the laryngoscele. Symptoms are the harshness of voice and the cough. If the cystic lesion is very large, obscuring the glottic region, they may present with this airway problem, breathing difficulty. So diagnosis by the indirect laryngoscopy and also as well as X-ray neck lateral view for the soft tissues or the CT scan, so that we can know the cystic lesion and also extension of this cystic lesion. So in this picture you can see patient is doing the Valsalva maneuver, increasing this glottic pressure by closing the nose and mouth and blowing the mouth, so that there is a pressure, increased pressure in the transglottic region. We will see the increased size of this laryngoscele. So you can clearly see this increase in size of the laryngoscele during this maneuver, so that we can confirm the diagnosis. If the size is increased, it is connected to the larynx. So treatment is surgical excision, depend upon the size type of the laryngoscele. If it is only internal type without any respiratory obstruction, marsupialization we can do, or total surgical excision by using the microlaryngoscopy. If it is external type, we can give the external incision and complete excision of this cystic lesion. Coming to the neoplastic lesions, in neoplastic lesions, so the most common type is papillomas, recurrent respiratory papillomas, or juvenile respiratory papillomas, and adult onset papillomas. So these papillomas may arise in the childhood or in the adult. So in childhood, if it is arising in the children's or childhood, so the most common etiology is the human papilloma virus infection by the type 6 and 11. So we'll see the multiple in number in the juvenile onset or in the childhood. In adult onset, usually we'll see the single papilloma. So it presents as the exophytic growth, often bulky lesion, and it causes the voice change, respiratory problem, and also swallowing difficulty. So you can see this clear picture, endoscopic picture. These are the free borders of the vocal cords. These are the papillomas. You can see multiple papillomas. Here the anterior commissure region and also anterior one third of the vocal cord. This is the commonest site. Vocal cords is the commonest site for the this origin of the this recurrent respiratory papillomas. So exophytic lesion extending into the aerodigestive mucosa. Treatment option is cold instruments or X-ray or CO2 laser, or by using the microdebrider laser and the microsurgical flap dissection. So microdebrider is nothing but it is a powered instrument. Usually you will use the this microdebrider in the functional endoscopic sinus surgeries. So here there is a precise rotatable blade with suction apparatus. So it will precisely cut the tissue and it will suck the tissue without any damaging to the underlying structures. That is the microdebrider. The other one is the granular cell tumor. So this neoplasm actually arising from the Schwann cells of the this nervous system. Approximately 50% you will see in the head and neck region, and most common site is the tongue. About 10% arise in the larynx, where they most commonly arise at the junction of the vocal ligament and the vocal process of the arytenoid cartilage as a submucosal mass of the size approximately 1 to 2 centimeters, and it is smooth in appearance, sessile, and firm in consistency. So lesion may appear pale or white on examination, particularly when infested with the candidal lesion. So on histology or this glandular cell tumor, we will see the polygonal or elongated cells with granular cytoplasm. It merges with the skeletal muscle cells. So the granules are periodic acid skip, that is the PAS positive, and may represent an accumulation of the lysosomes. Treatment is endoscopic removal or thyrotomy. So we need to open the thyroid cartilage. So they are sometimes multifocal, usually seen in the fifth and fourth to fifth decade. Incomplete excision has been noted to result in apparent long-term cure in some cases. Hemangioma, this is also important. It is again two types, capillary and the cavernous types of the hemangiomas. The most common site for the hemangiomas in the larynx is subglottic region. You can see just below the vocal cord there is a diffuse pinkish swelling in the subglottic region, and the symptom is the stridor, respiratory difficulty, because it is a narrow spot. It will obscure the airway, so patient will present with the respiratory difficulty. So exophytic mass in this subglottic region, that is most commonly capillary hemangioma. So biopsy should not attempt for the biopsy because it is a vascular lesion. It will cause the profuse hemorrhage during the biopsy. So if it is small tumor, you can attempt for the endoscopic excision. If it is large, external approach. So cavernous hemangiomas most frequently occur in the false vocal cord, and capillary hemangioma may occur both in the supraglottic region and also through vocal cords. So usually we'll see this congenital type of the hemangioma in the neonates in this subglottic region. Usually it is detected in infancy, occur mostly in the subglottic region. So there is a common association with the multiple cutaneous or capillary hemangiomas of the skin and the oral mucosa. So there is 5% association with the other congenital anomalies, and over 70% occur in the posterior part of the larynx or posterior tracheal wall. Usually it causes the symptoms in the first 8 weeks of life. Almost all these children will present with this stridor within 6 months of life. So diagnosis by video laryngoscopy or video stroboscopy. So lesion, if it is sessile, fairly firm but compressible, pink or red or bluish in color, poorly defined margins. So if you do the endoscopy, it may further compromise the airway. So already because of the mass lesion in the subglottic region, they'll have the respiratory problem. So if you if you want to do the endoscopy, first intubate the patient for the securing the airway, then do the endoscopy. So there are various treatment options for this subglottic hemangioma in the pediatric age group. So you can do the tracheostomy for the airway. You can observe for the spontaneous resolution. So the second option is you can put the prolonged endotracheal tube intubation with or without corticosteroid injection into this hemangiomas, or you can inject the sclerosing agents into this hemangiomatic lesions. Or use of systemic corticosteroids also will reduce the size of this hemangiomas. Cryosurgery, external beam irradiation, and laser excision. So the other benign lesion is the chondroma. So it is usually arising from the cricoid cartilage. The other cartilages are the thyroid cartilages. Most commonly, we'll see in the males in the age group of the 40 to 60 years. Male to female ratio is 4:1. The common symptom is because of mass dyspnea. If it is extending beyond the larynx, it will compression over the esophagus. It will cause the dysphagia. So we can diagnose this chondroma by the this CT scan on biopsy of the lesion. That is the gold standard to confirm the diagnosis of the chondroma. Treatment is by excision by the laryngofissure or lateral pharyngotomy. If the lesion is very big, you can go for the total laryngectomy. Glandular tumors are the pleomorphic adenoma and the oncocytoma. So other rare benign lesions of the larynx are the rhabdomyoma, neurofibroma, neurolemoma, lipoma, and the fibroma. All these lesions we'll see very rarely. So this completes the benign lesions of the larynx. Okay, Chanakya. Chanakya.
Yes, sir.
Yeah. Can you tell the classification of the benign tumors of the larynx? Classification. How will you classify? Any other this class?
Neoplastic, sir.
Hmm.
Non-neoplastic.
Okay. Non-neoplastic again.
Solid and cystic, sir.
Okay. Which is the commonest neoplastic lesion? Benign lesion. Commonest neoplastic.
Squamous papilloma.
Yeah. So the other name for this squamous papilloma? What are the types of squamous papilloma?
Juvenile and adult, sir.
Etiology? etiology for juvenile respiratory papillomatosis. So the other name is the juvenile respiratory papillomatosis or recurrent respiratory papillomatosis. So in the name itself, it is a recurrent respiratory papillomatosis. So that means, so there is a high chance for the recurrence after removal of this papilloma of the larynx. So the typical presentation is a respiratory problem with the hoarseness of the voice in the age group of the 3 to 6 years. That is the typical presentation of the recurrent respiratory papillomatosis. So if you exercise also, again there is a recurrence of this papilloma. So our aim of the surgery is to maintain the airway and to prevent the damage to the underlying vocal cords. So the common instrument which we use is the CO2 laser. So if you use the cold instrument, there is a high chance of the recurrence. If you use the laser, there is a less chance of the recurrence, less chance to damage the underlying structure. If the mass is very bulky, you can do the microdebrider. So to debulk the mass, we will be using this powered instrument, that is the microdebrider. So all of you should remember, if the lesion affects the vocal cords, the presenting symptom is the hoarseness or voice change. If the lesion doesn't affect the vocal cords, the main presenting symptom is the respiratory problem. And all subglottic lesions, the symptom is the difficulty in breathing or stridor. So in supraglottic lesions, depending upon the type of the lesion and size of the lesion, there may be a cough, difficulty in swallowing, or dysphagia, or hoarseness of voice if the lesion affects the true vocal cords.